What if the patient has cataract surgery and the lens in their eye is just not working as well as it should for that patient?
So lenses can be removed, meaning they can be exchanged should there be a problem, and that can be either a symptomatic problem. This particular patient had halos and glare that they couldn't tolerate, or the lens causes mechanical problems. This is a little vitrectomy trocar that goes in that just provides access behind the lens. As you know, vitreous is behind the lens, and during, especially if the capsule is open, like in this one, there's a tendency of the vitreous to come forward.
Yeah, that was already a big obvious difference in this surgery versus others. And how much of the vitreous is that actually going to be able to get out? Just, we say anterior, but is it pulling quite a bit out?
Yes, so this is a little cannula that has a anterior tip that basically allows me to go underneath the anterior capsule. This Rex is in a large size, so you saw some other videos where I make a smaller Rexes. This is one of the reasons I want to be able to easily open the capsule for an exchange and make sure that the anterior capsule supports a new lens. If it's very wide open, this is on the larger side, it's more difficult to get a new lens in that spot without additional help. And the vitreous that can be removed to this is a subtotal vitrectomy, a core vitrectomy, meaning the view would be clear to the back and nothing can prolapse through this opening. This is now sped up, and this is a cannula going around, lysing all those adhesions between the capsule and the lens, because the lens is designed to stay inside the eye.
And this is all what we're seeing is getting that lens out. Now, in a couple views, you'll see the reflections where you see that optic in the center, characteristic of the Vivity lens, which is what this is. For this particular patient, was not working well, was having some dysphotopsias and poor symptoms with it. And this is now just trying to get those haptics and get the lens out and away from the capsule.
And this is also a toric lens in addition. So again, this patient had halos and glare at night, which made it impossible for her to drive. You can see all these adhesions that basically keep the lens in place, and as I'm holding them back to slowly, carefully get the lens in the front part of the eye to make it more easy to remove. But again, these little thickenings keep the lens in place. That's designed to protect them from moving without purpose.
I imagine that's going to make it more challenging to put the new lens in as well with those adhesions there, or once you get it out, we'll see.
I was going to say, once you get it out, you should be good. And we'll go back in a little bit to just show the optic. This is just cutting that lens inside the eye, which, as you can imagine, is a bit more challenging. This bruise is more from me holding on to the eye because when I rotate and move things, I need a little more control than I usually have. This lens is under topical. I should say the patient is under block, meaning this whole eye is numb and they don't feel what I'm doing.
So the lens has now been cut in half, and we're seeing two halves of that lens. When we saw the removal of an ICL, that was not needed to be cut in half. This material is a more firm material, I assume, and also with the haptics, you're worried about that being pulled out, or what's the main reason this has to be cut in half?
Thicker and more firm. So the Collamer is very thin, easy to cut. Also, if you imagine or remember, a myopic lens is very thin in the center. This is a plus average 20 lens. So much thicker, much more rigid, and it's not as easily foldable as the other one. Here I'm just trying to get it just in the right position to get it through that small opening I created temporarily. And as you can see, this lens still folds, but the whole thing would have been a little difficult to remove. This is now the vitrectomy part, where I remove any gel that might have prolapsed. You can see some of the floaters being removed at the same time. Those are the same procedure that is used should the patient have floaters to remove them as well.
So amazing to watch. I love just thinking about the patient with their symptoms of floaters, and now they can come out of surgery without seeing those cobwebs or those strands in their vision.
Again, careful. Just want to repeat, this is sped up. This is not the normal speed.
Well, but we're seeing the full process here of
Yes.
how that's working, and still have the second half of the lens. And I feel like with the way the haptic is positioned, you can't just go straight forward and pull it out. So what we're seeing is a process to rotate that to allow it to be removed.
And that was the reason also for the vitrectomy, because during the movement and manipulation, it's more likely that things come forward. So removing the vitreous to make sure everything stays back, and then removing that second will make any kind of traction, which could lead to retinal problems, less likely. And as again, the second piece coming out, and you'll see that the haptic kind of folds and it comes out in one piece.
So now the lens is out, and we're moving on to the next phase of the surgery to prepare the eye and then have the actual implantation of a new 3-piece IOL.
This little wave that you saw is viscoelastic. Again, I use a 3-piece. This is a silicone 3-piece that comes out very nice and flat. So here, because I want to make sure it stays in the front part of the eye, I actually put it on top of the iris and then place it gently in the sulcus or in the bag, depending on where I feel most comfortable. I believe in this case I placed the haptics in the bag again, which can be done, but it is more challenging.
Yeah, that's subtle with the color of the iris there. It's hard to even see that color of the haptics, but there's the haptics. Just there, you can see them right now, just pulling right off the iris.
And then putting it
tucked in,
and then the same thing on the other side through a side opening.
And this is the second haptic. Same thing, just barely passing over the edge of that capsule, and now it's in. You have the full 3-piece lens with the haptics inside of the capsular bag.
And the reason for this additional manipulation, which is usually not necessary, is that this patient also has negative dysphotopsia, meaning they see a little shadow on the side of the vision. So I wanted to get the optic in front of the capsular bag, which is one of the treatments that decreases the incidence of the shadow on the side.
So right now we're seeing the optic, and that's actually in front of the capsule there.
There's a lot of 3D going on, and the only reason why I can tell is because I know I was able in there and touch it. So this is at the end. I tend to place a suture. This can be removed in the clinic at the slit lamp, and the patients do not feel this because it's underneath the surface. And I wanted to go back. So this is the Vivity, which has this central optic that's different, that's supposed to provide more depth, which it does, but it decreases the quality and again does provide some halos and glare at night. And for some patients, the trade-off is not worth it. Nothing is perfect. There is no perfect lens, otherwise we'd have no discussions. And this patient initially thought that she would be able to tolerate or would want more depth of focus as a trade-off for more visual symptoms. It turns out she would rather wear glasses and not have these symptoms.